Let's talk about an important topic, pheochromocytoma. Pheochromocytoma is a type of neuroendocrine tumor that grows from cells called chromaffin cells. These cells produces hormones needed for the body and are found in the adrenal glands. The adrenal glands are the small organs located in the upper region of the abdomen on the top of the kidneys. About 80 to 85% of the pheochromocytomas grow in the inner layer of adrenal gland, which is called adrenal medulla. Here, this is adrenal medulla where pheochromocytoma is grown. Most pheochromocytoma are benign, which means they are not cancer and do not spread to other parts of the body. Only the 10% of pheochromocytomas spread to the other part of the bodies. So, the classic triad for pheochromocytoma is headache. Headache is usually episodic headache. Second one is sweating, and third is tachycardia. The another important point that you need to know, and it is commonly asked in exam, is resistant hypertension or hypertension accompanied by unexplained increased glucose. So what do you mean by resistant hypertension, or how it can be tested in exam, especially in USMLE, where patient with hypertension comes to you and who is on at least 3 antihypertensive medications, and still his hypertension is not controlled, and there is episodic headache along with sweating, and then you can correlate that it could be pheochromocytoma. Now, family history or the familial syndrome like MEN2, NF1, VHL. Now, how to approach a case of pheochromocytoma? So, first thing you're going to do is urine or plasma metanephrine levels. The confirmatory test is abdominal imaging for increased metanephrines. Now, 10% are usually bilateral, 10% are extra adrenal, and 10% are malignant, as we talked about. So it is a rule, it follows the rule of 10. Now, how to manage this kind of patient? So pre-operative, you can give alpha blockers prior to beta blockers. This is a very important point that is commonly asked in exam. So we cannot give beta blocker initially because we need to block the alpha receptors as well. So alpha blockers is always given first, then the beta blockers. The laparoscopic or open surgical resection can also be done. Let's talk about if we suspect a patient with pheochromocytoma. So first thing we're going to do is 24 hours urine fractioned metanephrines and catecholamines. And secondly, we will do plasma fractioned metanephrines. Now, if it is normal, we need to recheck during spells. Okay, if there is a high level of metanephrines or catecholamines, then we need to go for CT scan or MRI of abdomen. If CT or MRI is negative, we can consider MIBG scan, octiotrite scan, whole body MRI, or PET scan. If it is positive, the CT or MRI of the abdomen is positive, we straight away move to surgical approach, either surgical evaluation, genetic testing, alpha and beta blockers. So alpha and beta are always given together because just now we talk about we cannot give beta blocker prior to alpha blockers because it will cause hypertensive crisis. We can also do MIBG scan if tumor is more than 5 cm and suspicion of extra-adrenal disease. Now, when we do surgical approach, when we go for the surgical route, there are some complications related to adrenalectomy. So that could be hypertensive crisis because of increased catecholamines, and it could be because of the increased norepinephrine if there is a large tumor more than 4 cm in diameter. And if there is hypertensive crisis, we need to treat it by intravenous nitroprusside or phentolamine or nicardipine. It can also lead to hypotension because there will be decreased catecholamine after tumor removal and persistent alpha blockage from pre-operative long-acting alpha blockers which we given before beta blockers. That was phenoxybenzamine. And to treat this, we will give normal saline bolus pressors if unresponsive. It can also lead to hypoglycemia because of increased insulin secretion during tumor removal, and will treat it by intravenous dextrose infusion. It can also cause tachyarrhythmias because of increased catecholamines, and we will treat it by giving lidocaine or esmolol. Thank you.